We are looking at an incidental finding in a 40-year-old patient who was referred for a brain CT due to non-specific headache syndromes with an otherwise completely normal neurological examination. Here on the side you see the thick slices without contrast, and here you see the thin slices reconstructed in multiplanar imaging in all the planes. The CT has revealed dense, highly symmetrical cortical and subcortical calcifications. You can see here and here, which are restricted entirely to the bilateral occipital lobes. Now, when encountering such symmetrical intracranial mineralization, a common initial thought would be Farr's disease or primary familiar brain calcification. But the location here is completely wrong. Farr's characteristically targets deep gray matter. Yet in this patient, the basal ganglia, thalami, and dentate nuclei are completely pristine. So to investigate further, we perform MRI without and with contrast enhancement. And the investigation is showing the prominent blooming artifacts on SWI sequences, but those are consistent with dense calcifications. However, crucially, the parenchyma on FLAIR imaging shows no surrounding edema, no gliosis. There is also absolutely no contrast enhancement. So the lack of vascular also changes allows us to completely negate Sturge-Weber syndrome, as a classic Sturge-Weber presentation would typically demonstrate unilaterally or symmetric marked cortical atrophy, leptomeningeal enhancement, and abnormal PL or deep medullary vessels, none of which are present here. Instead, this highly specific combination of isolated symmetrical occipital calcifications, spared basal ganglia, and quiet underlining parenchyma points directly to Gobbi syndrome, also known as CEC syndrome. Now, CEC syndrome is the clinical triad of celiac disease, epilepsy, and cerebral calcifications. Although often diagnosed in childhood due to occipital seizures, adult presentations can be completely asymptomatic or present with non-specific complaints like headaches. The underlying mechanism is thought to stem from chronic silent celiac disease, causing either folate malabsorption or immune complex mediated endothelial inflammation within the posterior vascular bed. Therefore, the essential next step in imaging of this patient is not further neuroimaging, but rather a screening with a celiac serology panel, specifically checking anti-TTG IgA levels. So this interesting case, if you like it, please consider reviewing my previous cases, liking and subscribing, and I see you in the next one.